In the 1970s, the landscape of prescription medicine was markedly different from today, with regulatory standards still evolving in the wake of earlier scandals and a more permissive approach to certain compounds. Doctors routinely prescribed substances for common ailments like pain, insomnia, anxiety, and obesity that, with the benefit of accumulated evidence and stricter oversight, have since been withdrawn from the market, heavily restricted, or rendered effectively illegal for most uses. These changes stem from revelations about addiction potential, cardiovascular risks, toxicity, or lack of efficacy outweighing dangers. What seemed routine then often appears astonishingly cavalier now, though it's worth remembering that medical knowledge advances through trial, error, and sometimes unfortunate hindsight. Here is an examination of 20 such medicines or classes of compounds that were commonplace prescriptions in the 1970s but are no longer available in their original forms or for those indications today. One of the era's most notorious sedatives was methaqualone, better known by brand names like Quaalude or Mandrax. Marketed as a safer non-barbiturate hypnotic for insomnia and muscle relaxation, it gained rapid popularity in the late 1960s and peaked in the 1970s, with millions of prescriptions written annually. Physicians appreciated its quick onset and euphoric effects, which patients often described as profoundly relaxing. However, recreational abuse exploded, earning it street names like disco biscuits for its role in nightlife. Overdoses, dependence, and reports of impaired judgment led to escalating controls. By 1984, it was classified as Schedule I in the United States, with no accepted medical use and manufacturing ceased. Today, legitimate methaqualone is unavailable worldwide in most contexts, a stark reversal from its over-the-counter status in some countries earlier. Amphetamine-based diet pills represented another staple of 1970s medicine cabinets. Compounds like dextroamphetamine, dexedrine, mixed amphetamine salts, benzedrine derivatives, and colorful rainbow pills, combining stimulants with sedatives or thyroid hormones, were liberally prescribed for weight loss. Doctors viewed them as effective appetite suppressants with a boost to energy, and patients sought them for quick results in an era obsessed with slimness. Formulations such as Obtrol or biphetamine, black beauties, were common. Yet addiction, hypertension, psychosis, and cardiovascular events mounted. While some amphetamines remain Schedule II for ADHD or narcolepsy under tight controls, broad use for obesity was curtailed in the 1970s, with many specific formulations withdrawn or reformulated. Non-medical possession is illegal, and the casual prescribing of the disco decade feels like a relic. Propoxyphene, sold as Darvon or in combination as Darvocet, was a go-to mild opioid analgesic in the 1970s, prescribed for everything from dental pain to postoperative recovery. Marketed as less addictive than codeine, it racked up tens of millions of prescriptions yearly. Evidence later showed it offered little more pain relief than acetaminophen but carried risks of cardiac arrhythmias, especially in overdose, alongside dependence potential. Public health advocates pushed for years. The UK banned it first in 2005, and the FDA followed in 2010, requesting voluntary withdrawal. Generic versions lingered briefly elsewhere, but it's now off markets globally, a quiet exit for a once ubiquitous pill. Barbiturates like phenobarbital, secobarbital, Seconal, and amobarbital were still frontline sedatives and anticonvulsants in the early 1970s, despite known overdose risks. Prescribed for anxiety, insomnia, and tension, they were seen as reliable, with Red Devils, Seconal, particularly popular. High lethality in suicide attempts and rapid tolerance prompted a shift to benzodiazepines. Most barbiturates became Schedule II or III, with prescribing plummeting. Many formulations were discontinued, and non-medical use is illegal. They persist in niche roles like anesthesia, but the broad 1970s usage is gone. Diethylstilbestrol, DES, a synthetic estrogen, was routinely given in the 1970s to prevent miscarriage and other pregnancy complications, a practice lingering from earlier decades despite emerging doubts. Millions of women received it. Links to vaginal cancer in daughters and other reproductive issues in offspring led to FDA contraindication in pregnancy by 1971, with full awareness growing through the decade. It was withdrawn for those indications and later most others. Today, it's rarely used and heavily restricted. Fenfluramine and dexfenfluramine, Pondamin and Redux, emerged later in the period but were prescribed off-label or in combinations for weight loss by the mid-1970s precursors. The infamous fen-phen combo peaked in the 1990s, but roots trace back. Valvular heart disease and pulmonary hypertension forced withdrawal in 1997. They are banned for obesity worldwide. Pemeline, Silert, was a stimulant for ADHD and narcolepsy in the 1970s, seen as milder than amphetamines. Liver toxicity reports accumulated, leading to voluntary withdrawal in 2005 after black box warnings failed to curb risks. Zomepirac, Zomax, was a non-steroidal anti-inflammatory launched in the early 1980s but with 1970s development roots, prescribed widely for pain. Anaphylactic reactions prompted withdrawal in 1983. Nomifensin, Marital, was an antidepressant available in some markets through the 1970s and 1980s. Hemolytic anemia risks led to global withdrawal by the mid-1980s. Bendectin or Debendox, a combination for morning sickness containing doxylamine and pyridoxine, with earlier versions including dicyclamine, was standard in pregnancies through the 1970s. Litigation over alleged birth defects, later debunked, caused manufacturer withdrawal in 1983, though components remain available separately. Ticrinophen, Celacrin, was a diuretic for hypertension, briefly marketed around 1980 after 1970's approval. Liver damage caused rapid withdrawal in 1980. Suprafen, Suprol, was an NSAID for pain and dysmenorrhea in the mid-1980s, with precursors in the late 1970s. Flank pain syndrome and renal issues led to 1987 withdrawal. Certain high-dose estrogen contraceptives, like sequential pills with high ethinyl estradiol, were common in the early 1970s. Thromboembolism risks prompted reformulation and withdrawal of those specific high-dose versions by mid-decade. Methapyraline, an antihistamine in many over-the-counter sleep aids and cold remedies through the 1970s, was found carcinogenic in animals, leading to removal from products by the early 1980s. Fenformin, an oral anti-diabetic related to metformin, was widely used for type 2 diabetes in the 1970s. Lactic acidosis risks, far higher than alternatives, resulted in U.S. withdrawal in 1977 and bans elsewhere. Oriflex, binoxaprofen, an NSAID launched briefly in the early 1980s after late 1970s development, caused fatal liver and kidney damage, withdrawn months after approval. Enconide and flecainide, antiarrhythmics studied in the 1970s and approved later, were prescribed post-MI until the CAST trial showed increased mortality. Enconide was withdrawn in 1991. Triazolam, Halcion, faced intense scrutiny in the late 1970s and 1980s for psychiatric side effects. While not fully withdrawn, it was banned in some countries like the UK and heavily restricted elsewhere. Estimazole, Hismanol, an antihistamine popular from the 1980s but with 1970s origins in research, caused fatal arrhythmias when combined with certain drugs. Withdrawn in 1999. Cisapride, Propulsid, for GERD, gained traction in the late period but was withdrawn in 2000 for QT prolongation and ventricular arrhythmias. These examples illustrate how pharmaceutical oversight has tightened. In the 1970s, post-marketing surveillance was rudimentary, and risks like subtle cardiac effects or long-term carcinogenesis were harder to detect without modern epidemiology. Many of these drugs were grandfathered under older approvals or promoted aggressively. Today, the FDA and equivalents demand rigorous pre- and post-approval data, pregnancy registries, and risk evaluation strategies. The shift reflects hard lessons. Efficacy must decisively outweigh harm, and mild alternatives often aren't when scaled to millions. It's easy to chuckle at the naivety, prescribing potent stimulants for dieting or sedatives with overdose margins narrower than a tightrope, but medicine then operated with the best available evidence. Patients benefited in some cases, yet the toll in addiction, organ damage, and rare catastrophes prompted reform. The 1970s marked a transitional era, post-thalidomide vigilance but pre-modern pharmacovigilance. Now, while no system is perfect, these withdrawn medicines serve as reminders that progress in drug safety is incremental, often paid for in hindsight. Expanding on the broader context, the Controlled Substances Act of 1970 itself reshaped many of these trajectories, categorizing drugs by abuse potential and medical utility. Substances once loosely prescribed fell under stricter scheduling. For instance, while cocaine had medical niches earlier, by the 1970s it was already Schedule II, but topical formulations lingered before tighter rules. Similarly, early benzodiazepines like diazepam, Valium, exploded in the 1970s as Mother's Little Helper, becoming the most prescribed drug. Though not banned, they moved to Schedule IV with warnings about dependence. Another class worth noting, phenylpropanolamine, PPA, in many cold remedies and diet aids through the 1970s and beyond. Stroke risks in young women led to voluntary removal in 2000. Terfenadine, Seldane, the first non-sedating antihistamine, was a 1980s hit but withdrawn in 1998 for similar cardiac issues as estimazole. Grepafloxacin, Raxar, an antibiotic, briefly used post-1970s research, withdrawn for QT risks. The pattern repeats: initial enthusiasm, widespread adoption, then accumulation of adverse event reports forcing re-evaluation. In the 1970s, annual prescription volumes for some like propoxyphene exceeded 20 million in the US alone, underscoring scale. Reflecting further, obesity treatments highlight regulatory evolution. After amphetamines' fall, alternatives like fenfluramine filled the gap, only to repeat history. Today's options like GLP-1 agonists undergo far more scrutiny. Pain management saw parallels, from propoxyphene to later opioids, though the crisis peaked post-2000s. Sedatives transitioned from barbiturates and methaqualone to benzodiazepines, then non-benzos like zolpidem, each wave addressing prior flaws while introducing new ones. Antidepressants like normofen gave way to safer SSRIs. The 1970s thus bridged an era of relative laxity to modern caution. Doctors then might prescribe Quaaludes for stress or amphetamines for fatigue with minimal hesitation. Today, guidelines emphasize non-pharmacologic options first and monitor closely. This list isn't exhaustive. Hundreds of formulations have been discontinued, but these 20 capture the spirit. Once normal medicines now consigned to history's cautionary shelf. They underscore that medicine is a science in progress, where yesterday's standard can become tomorrow's prohibition, always aiming for that elusive balance of benefit and safety.